Hi guys, we are going to start today a soft tissue sarcoma made easy series. So today we have one case. 25-year-old male presented with non-healing ulcer in the foot. So what do you understand? The history clue is he's a young adult, right? A male. Non-healing ulcer in the foot. So what are the conditions or the sarcomas which are common in young adult? Those are synovial sarcomas, epithelioid sarcomas, alveolar soft bud sarcomas, desmoplastic small round cell tumor, extracranial meningiomas, clear cell sarcomas, and epithelioid MPNST. Then what are the sarcomas which are common in the foot and they present as non-healing ulcer? See, this is a gross picture of this soft tissue tumor which is destroying the bone and infiltrating into the soft tissue and also causing the ulceration of the overlying skin, right? So with this, what are your differentials? Like sarcomas which are common in the acral sites, like your hands, foot and extremities. So most common are your glomus tumor. Usually glomus tumor are benign tumors. They will not cause this extensive tissue destruction. Even sclerosing perineuromas are also benign tumors. They don't cause this extensive destruction of bone, soft tissue and overlying skin. Myoepitheliomas will have the myxoid appearance, but this is more of a fleshy and hemorrhagic and angry looking tumor, right? Clear cell sarcoma can be a possibility. Ossifying fibromyxoid tumor, we are not seeing any specks of bone or calcification here. Giant cell tumor of tendon sheath can be possibility. Synovial sarcoma can be a possibility. Okay. Then after this, we had a H&E slide. In low power, we could see a nodular appearing tumor with a necrosis. And this is a palisading necrosis with the palisading areas are surrounded by this epithelioid looking cells. They have the abundant eosinophilic cytoplasm. Let's see in high power. So those cells are looking epithelioid. See, somewhat round to polygonal with abundant eosinophilic cytoplasm. Here they are little bit spindly, showing mild to moderate nuclear atypia. And these tumor cells are infiltrating this dermal collagen, if you see. Then here is the areas of necrosis with severe nuclear atypia and mitosis, right? If you could see. Then this is that necrosis which is lined by this palisading tumor cells which are epithelioid looking, right? Okay, so now your close differentials becomes granulomatous lesions. But remember, like tuberculosis, leprosy, granuloma annulare, rheumatoid nodule, these are granulomatous lesions, but they don't destroy your bone and soft tissue, right? So that's why they are ruled out, but you can still get confused with them because this looking like a granulomatous, right? Then you see this is a necrosis, right? And these are lined by the tumor cells. So this is a palisading necrosis. The edges are lined by this epithelioid looking tumor cells. And inside the tumor, there is a hemorrhage. So you can get confused with pseudoangiomatoid appearance. Okay, because of the intratumoral hemorrhage. Then on high power, we could see the tumor cells which are having vesicular chromatin with prominent nucleoli. See, this is an epithelioid looking cell, no, which is have abundant to moderate amount of eosinophilic cytoplasm. So what all the sarcomas which are epithelioid looking and will have a vesicular chromatin with a prominent nucleoli. That is your extrarenal malignant rhabdoid tumor, epithelioid sarcomas, epithelioid angiosarcomas, epithelioid malignant peripheral nerve sheath tumor, alveolar soft part sarcoma, rhabdomyosarcomas, clear cell sarcomas, and epithelioid leiomyosarcomas. So then, to find out what it is, we have done the IHC. And this is a cytokeratin. Usually cytokeratin is a membranous staining, right? So all this was the necrotic area. the surrounding epithelioid cells have taken up for the cytokeratin. Remember, if it was a granulomatous reaction, usually this might be your epithelioid histiocytes. If it was a granulomatous reaction, right? Epithelioid macrophages or histiocytes, they will be negative for your CK and they will be positive for your CD68. So that's why this is definitely not a infectious granulomatous lesion. Then we have done this INI1. These are the internal controls of your endothelial cells and lymphocytes, which have taken up the stain, but whereas the tumor cells are negative. That is, INI1 is lost in the tumor cells. What are the internal control? These lymphocytes and the endothelial cells. So with this, the diagnosis is epithelioid sarcoma. So epithelioid sarcomas are mesenchymal neoplasms of uncertain differentiation. They are seen in less than 1% of adult soft tissue sarcomas. They can exhibit complete or partial epithelioid cytomorphology and immunophenotyping. We don't know the cause. More common in the males, young males. Clinically, you have two clinicopathological subtypes. One is called as classical or distal or conventional type. Another is called as proximal type or large cell type. Let's see the differences between the both. In classical type, it is more common in the acral sites, where in the proximal, it is more common in the truncal. Here it is superficial, it is deep-seated. It is common in the younger age group, whereas proximal is common in the little older age group. Here it presents with the painless nodule, slow growing and non-healing ulcer. Here it is rapidly growing, more infiltrative growth. Here you get confused with the pseudogranulomatous growth or pattern. Here the tumor cells will be arranged in sheets and nests. Both of them can have epithelioid features. Here you can have spindly and epithelioid. Here you will have a sheets of epithelioid cells with nuclear atypia. Both of them will express cytokeratin and there will be loss of INI1. This has more aggressive course, whereas this has protracted clinical course. So this is a pictorial representation of the classical form, where you have this nodular appearing and the central necrosis. They will collapse to form the central geographic necrosis. And you see when the individual nodule, the central area will have this necrosis. Periphery, you see this epithelioid or spindle tumor cells. At periphery most, you have the chronic inflammatory cells. So this you get confused with the granulomatous lesions, right? Then coming to the proximal form, you will also have here multinodular. We'll not see much of necrosis here. The tumor cells are arranged in sheets like growth pattern. The individual tumor cells have epithelioid cells with a vesicular chromatin and prominent nucleoli. Also, you can see sometimes rhabdoid type of cells. They are in the myxoid stroma. Okay. So the diagnostic criteria based on the site, location, age, we call them as proximal and distal type, right? Then it should be positive for cytokeratins and there should be INI1 loss. Correct? Then, now if you are seeing a predominantly granulomatous like appearance, you should rule out your granuloma annulare, rheumatoid arthritis. In those, the epithelioid cells won't be positive for CK, correct? They will be positive for your histiocytic marker, that is CD68, and INI1 will be retained, correct? And history also will help you. Then if you're seeing lots of epithelioid looking cells, then most common is your squamous cell carcinomas, which will be positive for P40 because cytokeratin won't help you in this case because cytokeratin is positive in your epithelioid sarcomas also. So P40, P63 will help you and INI1 will be retained in squamous cell carcinomas, right? Melanoma also will have prominent nucleoli, right? Vesicular chromatin. It can be arranged in mesh sheets. So that's why it will be positive for your melanocytic markers. Few melanocytic markers like Melan A, S100, SOX10, HMB45. All these will be positive. And your INI1 will be retained, right? Then you have malignant mesothelioma that arises from the mesothelial cells lining your pleura and peritoneal cavity. They will be positive for WT1 and calretinine. right? Epithelioid hemangioendothelioma and epithelioid angiosarcoma, these are the vascular tumors. So they'll be positive for your CD31 and CD34 and ERG. INI1 will be retained. But there is a pitfall. You know, up to 70% of your epithelioid sarcomas can be positive for your vascular markers. So only your INI1 will help you in distinguishing the epithelioid sarcoma versus your epithelioid hemangioendothelioma and epithelioid angiosarcoma. Okay. Epithelioid MPNST will be positive for S100 and INI1 will be retained. Coming to extrarenal malignant rhabdoid tumor, there also you will have INI1 loss, right? And even in your epithelioid sarcoma also INI1 loss. So what other markers will help you is CD99, CD56, SAL4 and glypican will be positive in your extrarenal malignant rhabdoid tumor. And these are more common in the children and infants, whereas epithelioid sarcomas are common in the little elder age group, right? Myoepithelioma and myoepithelial carcinoma of soft tissue are positive for your myoepithelial markers. If you see more of a spindle appearance, then your differential will be clear cell sarcoma of kidney, which will be positive for BCOR and cyclin D1. Okay. Then pitfalls is the most common one. What happens is in these epithelioid sarcomas, you tend to have this vacuoles sometimes. Those vacuoles can mimic like your vascular tumors, as I told you. So that time you tend to confuse with the vascular tumors and you put in your IHC panel the vascular markers like ERG and CD34. They will be positive in epithelioid sarcomas. Only your INI1 loss will help you. So what are the different adverse prognostic factors for epithelioid sarcoma? Old age, deep location, tumor size more than 5 centimeters, nodal involvement, proximal type, high mitotic activity and rhabdoid cells are associated with bad prognosis. So INI1 is a nuclear marker. So this is called a retained INI1. This is called lost INI1. It is lost in the tumor cells. These are the internal control. What do you mean by mosaic pattern? Means you have a alternating positive and negative in the tumor cells. That is called mosaic pattern, just for your understanding. Okay. So if you like the video, please subscribe to our channel. For more such courses, please call on this number. Thank you. Hope you liked our class.